Claire. Thanks for being available this morning. It's so good
Oh,
to
yeah,
see
no
you.
problem. Good to see you too. Bright and early for you.
You know what? Yes, it turned out it was kind of a busy morning before my morning even started. So, yeah, it's good to see you. I'm really excited to get into today's topic. Looks like we've got some followers joining us this morning.
Okay, great.
Um, this is Dr. Rinku Mehra. She is a board certified pediatric endocrinologist. For those of you who might not be aware, endocrinology has to do with the organ system that kind of governs our metabolism and things of that nature. And today we're particularly interested in talking about prediabetes. I kind of think that some people might kind of wonder what prediabetes is, but I'll let you introduce yourself too, Dr. Mehra.
Sure. Yeah. My name is Dr. Mehra. I'm a board certified pediatric endocrinologist, and I'm also board certified in obesity medicine because I spent
Fantastic.
a lot of my career really talking to patients about weight and diabetes prevention, type 2 diabetes prevention in kids. And so I got my obesity board certification. And I'm
Fantastic.
currently located in Virginia, but I do telemedicine currently in about 4 states, so Maryland, Virginia, Iowa, and Florida. Uh,
Fantastic.
and I feel like there are a lot of questions about um, weight in kids and what's healthy and not healthy. And so, I'm happy to spread that
Right.
message and answer questions.
Well, and I think part of it, so I'm a general pediatrician here in Portland, Oregon, and I see kids from newborn all the way up until about age 21.
Mhm.
And, I am the sort of pediatrician that would send patients to an endocrinologist if I thought that they were having issues with, controlling their blood sugars because they're pre-diabetic. Or a lot of times, and we did see a lot of this during the COVID pandemic, were children whose body mass index really kind of increased significantly because of the lack of activity, because kids were kind of home from school and not getting the same amount of activity that they would just by walking to school or walking around in school or even participating in PE. And so I found in my practice that I had a lot of children who I was worried about that were having pretty significant issues with fast weight gain, and worried about them, maybe even developing type 2 diabetes. And so I would do these workups, and then I'd find out that, the endocrinologists here just really, I think part of it was they were overwhelmed, but really didn't have like a great infrastructure to help children kind of get slim and trim to a healthier body weight.
Mhm.
So I'm really grateful that you're in this space doing this kind of work, because there's definitely a big need for it. So let's talk a little bit about prediabetes. For people who don't know what that is, how do you define it?
So, pre-diabetes is really, if you want to think about it, it's the stage that you're in before you develop full-blown diabetes.
Okay.
Okay. So the definition of diabetes is if you have a fasting blood sugar, so if they come into the office and you draw blood on them, they're fasting. If the fasting blood sugar is over 126, then that's considered diabetes.
Hmm.
Or if there's a random blood sugar that you check that's over 200, that's diagnostic of diabetes. And so really that's the definition of diabetes. And pre-diabetes is really before that stage, okay? It's also defined by a measurement called a hemoglobin A1C,
Hmm.
which we as physicians all know about, but really that tells us, what percentage of your red blood cells have sugar essentially attached to it, okay?
Right. Okay.
And so if you have pre-diabetes, diabetes is a hemoglobin A1C of 5%, 5.7% or more. And then pre-diabetes is really between that stage of 5.4 to 5.6 or 5.3 to 5.6, depending on who you talk to. But
Okay.
but really it's, a certain percentage of your red blood cells have sugar attached to them. And you're kind of in that phase where you're really at risk to develop full-blown diabetes. But you haven't quite got there. And it is important to know if you have prediabetes because, the risk of developing full-blown diabetes is pretty eminent, essentially, unless you make a change.
Hmm.
So if you check a blood sugar in the morning and it's 100 to 125, that's suggestive of prediabetes.
Gotcha.
Because 126 is our hard cutoff for diabetes. And I don't know why it's, 126 and not 125, but it's, 100 to 125 is prediabetes. And then if you do a random blood sugar and it's, 140, then 140 to 200 or 199, that's really considered prediabetes. And so that's really important to know what those numbers mean. The other thing that's important is sometimes you can have symptoms even if you have prediabetes. So you can have symptoms like for a child, drinking a lot, drinking that's just unusual for the child. Like, they're drinking more, they're peeing more. For young kids, I often say, look at the back of their neck, right? In the back of their neck or under their armpits, they can have this dark patch of skin there, and it's not dirt.
No.
And so I have patients who come to see me and say, oh, we've been scrubbing this and it's not going away. It's not dirt. It's the thick, thickened skin behind the neck because they have higher levels of insulin. And that insulin can help not help, but that makes that skin get thicker.
Right.
And so that is also suggestive of, prediabetes or diabetes coming.
So I guess the question that kind of came to my mind, and I think I know the answer to this, but just for our followers out there, like, can kids get prediabetes just as easily as adults?
Yes. Yeah.
Okay.
Yeah. Kids can get prediabetes, kids can get diabetes. And when we're talking about prediabetes, for the purposes, I guess, of our conversation here, we're talking about type 2 diabetes for prediabetes, right? So type 1 diabetes is where your body just doesn't make insulin. It used to be called juvenile diabetes. And that is a whole, different disease process altogether. Your body cells just cannot make, your pancreatic cells cannot make insulin. And so that's a separate process. The symptoms are the same: drinking a lot, peeing a lot, rapid weight loss. But what we're talking about is when we talk about prediabetes, and when you talk to a healthcare professional or, just the general public about prediabetes, we're talking about type 2 diabetes, which traditionally has been an adult disease. So it's typically seen in adults. We didn't really see a lot of type 2 diabetes until recently, because now we're seeing that kids are gaining weight rapidly. And they, have a harder time processing the food that they're eating with the insulin that they currently have. So we all have a little bit of insulin. It helps us to regulate our blood sugars. When you have too much, food or food that gets converted to sugar in your body, you just don't have the reserve. You don't have enough insulin to process that.
So is that where parents should start to worry then, is if they notice that their children are really kind of gaining weight rapidly, that would maybe be like a good reason to go in and see a regular doctor like me. And then if we do blood tests in the office or even outside of the office and do those fasting blood glucose and fasting insulin, and it's elevated, then we send them to a pediatric endocrinologist like you.
Yeah.
So after we've kind of made this diagnosis of prediabetes, like, what do we do? Like, how can we help? And is it something that we could actually like reverse?
Yeah. So, to be honest, when I've been working in academic centers and private practice for over 15 years. And I think that was, as an endocrinologist, I didn't really have time to counsel my patients often on like, similar to what you said, on prevention. Now, after I got my obesity board certification, I really focus on prevention of diabetes before we actually get to prediabetes. Meaning that, at every visit for you, you're counseling your patients on, their, weight as a measurement. So we don't want to, talk about, shaming the child for their weight. And sometimes patients, pediatric patients don't want to come to the doctor because they don't want to talk about their weight. And so, so I think it's important just to assess this as an overall health issue, just overall for the family. What's their eating pattern like? What's their activity like? And really having a good discussion about that. But we just want to focus on being healthy and preventing diabetes, because diabetes does have long-term health complications. So you can lose your vision, you can lose your, you can have difficulty with your nerves, you can have difficulty with going to the bathroom, difficulty healing from wounds. For young kids, they can get infections and they don't heal, or they can get yeast infections. And so really important to keep them healthy. So I think having a discussion with a pediatrician every visit to say, is there anything that you want to discuss about, your lifestyle, your weight, and then focusing on, more of a prevention. There are some, obesity medications that are approved for children now, and sometimes
Okay.
I say if their body mass index or their weight is just going up despite whatever they're doing, they're following a healthy lifestyle, they're exercising, they're dieting, whatever they're doing over a 6 to 12 month period of time, then sometimes there's a discussion to say, are there other medications that we can use to help prevent diabetes?
Wow.
So
So what kinds of medications would you recommend for a child that was in that situation where they've done all the things, they walk to school, they take a healthy lunch, they're making good food choices, they're active. Some kids like to be active and some kids not so much, but like what do you offer them?
So there's a whole line of medications, and so we kind of go through. It really depends on the age of the patient. It depends on what their we call it comorbidities or what other risk factors they
Hmm.
have. For example, if they have ADHD, also we
Hmm.
would offer medications that like phentermine is something that's sometimes given in conjunction
Okay.
with diet and exercise, but that's approved for 16 and above. So we really have to look at the age criteria for the patient.
Gotcha. Hmm.
In somebody who has migraine headaches, we could talk about Qsymia or topiramate. And so again, so there's certain age
Wow.
criteria for that, and there's limitations for what we give. I mean, the one that I traditionally was giving, not for weight loss, but really for the pre-diabetes phase, was metformin. So, metformin's been around for a long time.
Hmm. Right.
And we offer that medication, sometimes for our patients with prediabetes to prevent full-blown diabetes.
Right.
And then, the other ones like semaglutide or Wegovy's been approved recently for 12 and above.
Okay.
And
Oh,
so,
that's good to know.
yeah, so
Wow.
sometimes we talk about that and say, is this something? I think it's important to emphasize, though, that the medications are to be given in conjunction with diet and exercise. And so we want to make sure that we really focus on that, like healthy lifestyle. I think the
Hmm.
American Academy of Pediatrics recent guidelines said 26 weeks of diet and exercise counseling need to be given in addition to talking about medications or giving medications. So we don't just want to
Okay.
say, here are the
Right.
medications and just go and do whatever whatever you were doing. We really need to focus on eating a healthy lifestyle. If you're already doing that, which a lot of my patients are,
Hmm.
they've already been doing everything. And I believe that
Right.
they have been. And so, there's a lot of factors that are involved with genetics and environment,
Hmm.
African American, Alaskans, Native Americans, they have a higher risk of developing type 2 diabetes.
Right.
And so sometimes, they've tried everything and they're on that road, or they're already at that point that they're developing prediabetes. So we really want to focus on, can we offer some of these medications with a healthy lifestyle to
Right.
prevent.
So, okay, so as you said, diet and exercise are a huge component of making a difference for a child that is pre-diabetic.
Mhm.
Um, who can people go to for that kind of help? Because I know what I'm able to offer here in my clinic, and I mean, I don't really have like a program that's sort of, built up to have some accountability and a lot of guidance. Where would parents find that sort of a resource?
Well, I mean, if they were located in my area, they could come see me because I do have that resource available.
Oh,
So
fantastic.
I do check-ins with them sometimes weekly, sometimes every other week. And then we go over, at least monthly, we go over some things to go through, like what are changes that we can make this month to our diet. Sometimes it's a little overwhelming. They don't want to talk to me every week. But I have a course that I'm about to put out pretty soon, very soon at the end of June, that's going to talk about just the basics of diet and exercise. So we're going to talk about that for kids and families. And then, I think traditionally we've always said pediatrician, nutritionist, and then endocrinologist. I mean, those
Right.
are the three resources that people have. There are certain centers, certain hospital centers that have weight management programs, and that may be a good resource.
Hmm.
I think local gyms or YMCA's always have some challenges that they offer.
Right.
That you can do like a 3-month challenge or something
Hmm.
like that. I think the important thing for patients and parents to know, though, is that the weight does take time to come off. And I think this has to be, it's not going to come off overnight. So we have to have a dedicated plan to focus on being healthy overall.
Right.
And
Right.
a lot of times for kids, I used to say, well, let's not focus on a diet per se. Let's just say, let's maintain our weight and then we grow into our weight, right? Because
Mm-hmm.
we don't want to push kids into a spiral of having an eating disorder,
Right.
saying, I can't eat this and can't eat that. So we really talk about, the food that you're eating, what is it providing for you? Is it going to provide, what kind of, like we talk about food as medicine. So
Right.
what kind of nutrient is that going to provide for you? Well, let's
Mm-hmm.
focus on your protein. Like the protein's going to build muscles for you and make you run faster and swim faster. And then we talk about, fruits and vegetables. So they provide, minerals, nutrients, vitamin C, and that's important to build, like have healthy hair, healthy skin, like overall just, feel good.
Right.
And then you need dairy and to help build your bones. And then sort of anything you have, a little bit beyond that is, if you're hungry enough, you can have a little bit. I mean, we talk about portion sizes as
Okay.
far as what's the appropriate portion size for, protein and carbs and fats. And so I think there's even myself as a parent, I didn't know the right portion sizes for my kids. So
Right. Like, how would you know?
you don't know, and you don't, yeah. So I think that's, something that we have to recognize as pediatricians that there are not a lot of resources
No.
around.
Right.
There are not. It's either, you're Googling or you're going through what is appropriate for your family. So the way that your family grew up, the way that your family ate as you were growing
Mm-hmm.
up.
Right.
And oftentimes parents offer the same types of food. And I will tell you, I'm doing a health fair this weekend in Maryland on diabetes. And, I'm Indian and I grew up in an Indian household. And the food that we ate growing up tasted really good, but it's not, it's not healthy for you. And so I think, and no one ever told
Right.
me that, right? Like no one
Right.
told me that this
It's
had like,
cultural.
right. It's very cultural. And so I think that's okay to do that in moderation, but
Right.
there's a lot of discussion that we need to do with that.
Yeah. As you say that, I was just thinking, I grew up in Hawaii and, I now live in Oregon, and I have kind of a different frame of mind when I look at the foods that we ate when I was a kid. I mean, we drank a lot of juice.
Mhm.
We drank a lot of soda because it's hot and like you need to rehydrate. And so that just was readily available. And, now in my
Right.
household, we don't have either. And yet these are things, from my childhood that do kind of become part of like, your culture, or like we eat rice with everything and
Right.
it's white rice.
Right.
But if you kind of go back to the roots of like the way the Hawaiians used to eat, there are things that culturally are, acceptable in our community as, as Hawaiians that are actually really healthy, like lean fish.
Mhm.
You can eat taro leaves and it's kind of the equivalent of spinach, and sweet potato is a huge part of the diet. So I think we can sort of look at the way we eat and sort of refine it a little bit so that we can make healthier food choices
Right.
within what is sort of a cultural norm
Right.
for whatever culture people come from. So that's really fascinating. And you're right. Like we don't really. How would a parent know what a normal portion size would be? Um, yeah, no, this is absolutely fascinating. So have you seen children who are pre-diabetic go back to not being diabetic anymore after treatment?
Yes. Yes. And we see that, very often. And really that's our
Okay.
goal. Our goal is to prevent diabetes development. And yes, absolutely. We see that hemoglobin A1C go down for type 2 diabetes. It kind of depends, sometimes some patients have to work a little bit harder to get it to come down.
Okay.
Certainly we can get the A1C to come down with medication, but sometimes I have been able to take patients off of all medication because they really adopt the lifestyle changes uh,
Okay.
pretty rigorously. So yes, it is preventable. It's preventable and it's reversible too.
Oh, that's fantastic. So there's a lot of hope. So if somebody out there has a child that has had an increasing body mass index and has been diagnosed with prediabetes, there's hope that that is actually
Right.
reversible
Yeah.
and they can kind
Yeah.
of go back to their norm
Right.
and not have to worry about it.
Right. Right.
Fantastic. That's great. I'm wondering, we have a couple of viewers out there. If anybody has questions for Dr. Mehra, go ahead and post them in the comments. It's good to hear this about diabetes though, because our pre-diabetes, because I do, when I see children in my office, I do spend a lot of time talking about diet. We talk about exercise. Also, as a general pediatrician, my focus is to keep kids moving. So I take, any little ache and pain that they have that's preventing them from participating in PE, take it very seriously. Like if asthma is preventing them from participating in PE, well, we don't just write a school note, but we try to get to the root cause, which is let's get your asthma under control so you can participate, because we don't want that to be a reason to slow you down. Because as we know, like as children, like if for any reason any human slows down, it's very easy for the weight gain to start to accumulate, and then it makes it harder to move and less desirable to move and exercise. Don't see any questions out there, but gosh, this has been a really good discussion. So if people want to work with you, you mentioned this before, you have a medical license in 4 different states. Where can they find you if they want to work with you?
Yeah, so I'm on Instagram at Dr. R. Mehra. And then if they want to contact me, they can contact me. My office phone number, which is 703-940-0635. I will say that I don't, if they want to contact me through Instagram, they probably have to send me a private message, because I think that's really hard to keep track of that otherwise.
Yeah.
But my website is www.TheMehraClinic.com, and so they can certainly find me there.
Okay.
But I wanted to make one last point about that comment you made about a child with asthma. I think the important thing for us to think about as pediatricians and recognize now, the American Academy of Pediatrics did come up with a statement, and I recently went to the Pediatric Endocrine Society conference, and they made the same statement to say that obesity and weight gain in children actually should be considered a chronic disease, just like asthma.
Oh,
and
absolutely.
So if we are going to, we need to start focusing on treating weight gain in children the same as we would treat asthma. So it's a chronic condition, it's lifelong. There's genetic factors that are involved. There's family and society factors involved. For example, if you have a child with asthma who lives in a home that someone's smoking, that's going to be detrimental, right?
Right.
So same thing with obesity. There are family and genetic factors that are involved. So I think that's very important to recognize. And I think as a medical community, that's new. That's been new this year, that we're, now saying that obesity is a chronic disease.
Well, and I think part of it, as you mentioned, like the environment really kind of adds to it. Part of it may be, as we discussed before, the way that we cook culturally and what's culturally acceptable and the way a household runs. And so, and I do kind of look at this as a general pediatrician a little bit more holistically, is like, it's not just, and you do too, it's not just the patient in front of you, but it's the context that they live in, right? The way that their family lives. And so, it almost seems that to really have like an effective outcome for the child, if the child is pre-diabetic, there has to be kind of a big change in the household. Like we all kind of have to start making better food choices. And so I think that's really where it's helpful to have that continuity of care with a pediatric endocrinologist, with a, with a program that's kind of built up to provide that kind of support or continuity of care with, general pediatrician.
Right. Exactly.
Yeah. Well, I'm so glad that you're out there doing this work. Your patients need you. I can think of a bunch of my patients that could really use your help. If you are going to get your medical license in Oregon, that would be so awesome.
Right. Yeah, they're on my list. I have a couple on my list. So Oregon's definitely on my list. Yeah.
Okay. All right. So they can find you on your website at TheMehraClinic.com. I'm Dr. Kirin Palmer. It's really been a pleasure to chat with you, Dr. Mehra, this morning. Oh, I have one last question. I was going to ask you. Juice. People will always, they're always worried about like juice consumption, sugar consumption, if it's candy, causing diabetes. What do you say? What do you say to that?
I would say one time, or occasional having juice or, candy or treat occasionally for special occasions is okay. But over the long term, I think if you're drinking juice every day, that's added sugar and added calories, and you don't really need that. And so it's a combination of weight gain and insulin resistance that leads to diabetes.
Right.
And certainly juice and candy contribute to that. So, yeah.
So one every once in a while is okay.
Right.
All right.
Right.
That's great.
Yeah.
Well, this has been really fun. I think that our viewers out there are going to get a lot of really good information, and hopefully they will be able to find you on your website. I'm Dr. Kirin Palmer at Pure J Pediatrics. If you're looking for a general pediatrician in the Portland area, look us up. It was good to see you.
Take care.
Take care.
Bye.